Thanks for joining. We're going to get started in just a moment. Is the room open, Camila? I don't see any participants. Just want to make sure.
Yes, they are joining.
Okay, great. So thanks everyone as you join us for today's webinar, Innovations in Mobile Health to Increase Health Access for Domestic Violence and Human Trafficking Survivors. Today we're providing closed captioning, ASL interpretation, and Spanish interpretation. And I'll turn it over to our Spanish interpreter, Andrea.
Thank you, Ana. Hi, everyone. My name is Andrea, and I am here with my co-interpreter, David. Today, we will be providing simultaneous Spanish interpretation, and there will also be ASL interpreting as well as captioning. Please follow these instructions so that you may access all the services if you wish so. And I will also be providing these instructions in Spanish as well. Hola a todos, yo soy Andrea, estoy aquí con mi cointérprete David y vamos a estar interpretando simultáneamente al español. También habrá disponibles subtítulos en inglés automáticos y no automáticos, perdón. Y también tendremos interpretación de señas estadounidenses, para lo cual podrán seleccionar para poder resaltar a las intérpretes en la sesión. Siga mis instrucciones para que pueda seleccionar su canal de interpretación. Okay, so if you're joining through a computer at this time, you should be able to see a globe icon at the bottom of your screen that says interpretation. Please go ahead and click there, then select English and do not mute original audio, and then select done to activate this selection. This will help you just to listen to the interpreter's rendition in case anybody participates in a language other than English. Okay, if you're in a tablet or a smart device, simply tap lightly on the screen to bring up the three-dot menu, then select language interpretation, English, do not mute original audio, and then to activate, tap done. If you would like to see the ASL interpreters, please go ahead and pin them to the screen. You can find them by their name, which will start by ASL. And then interpreters. Muy bien, si se está uniendo a esta sesión a través de su computadora, en este momento puede ver un icono de globo terráqueo en la parte inferior de su pantalla que dice interpretación de idiomas. Por favor, seleccione aquí, después seleccione español. Si solamente desea escuchar al intérprete, puede silenciar el audio original y después active esta selección con listo o done. Si está en su tableta o teléfono o dispositivo inteligente, toque la pantalla ligeramente para ver el menú de 3 puntos. Después seleccione interpretación de idiomas. Después español. Puede silenciar su audio original para solo escuchar al intérprete. Y después listo o done para activar. Necesita la aplicación de Zoom para poder escucharnos en español. Si tiene algún problema o no nos puede escuchar, nos puede poner algo en el chat y uno de nosotros le ayudará. If for some reason you're not able to hear the Spanish interpreter, or you're not able to see the ASL interpreter or the subtitles, the captions, please let us know in the chat and one of us will help you. Thank you, and pass it back to you, Ana.
Thank you. And thank you to our interpreters and our captioner today. So this webinar is sponsored by 2 of our projects at Futures Without Violence. Health Partners on IPV and Exploitation is a TTA project that's funded through HRSA's Bureau of Primary Health Care to work with community health centers to support those at risk of experiencing or surviving intimate partner violence, human trafficking, exploitation, and to bolster prevention efforts. We offer webinars like the one today, ongoing learning collaboratives for small groups, and we have a range of clinical and patient tools. Next slide. It's also sponsored by our National Health Resource Center on Domestic Violence. which supports all kinds of professionals, including healthcare professionals, domestic violence experts, survivors, policymakers, as they improve the healthcare's response and prevention of domestic violence. Next slide, please. So I'm Anna Mariavi, and I direct our project Health Partners on IPV and Exploitation at Futures Without Violence. And I'm joined by 4 featured speakers today, and they're going to introduce themselves in the order that they'll be speaking today. I'll hand it over to James.
Hi, everyone. My name is James Como. I'm a licensed clinical social worker, and I'm the Senior Executive Vice President of Operations at Access Health Louisiana, which is a federally qualified health center network. I also come to you with my second hat, which is a member of the Mobile Healthcare Association Board of Directors. And I'm the faculty member for the intensive training course that the association puts on for folks that are looking at new mobile programs.
And Dr. Ebony Winford.
Hello, everybody. I am Dr. Ebony Winford. I'm a licensed psychologist and the Director of Research and Health Equity at Cherokee Health Systems. We are a federally qualified health center in Tennessee with 21 locations, serving 13 counties, 70,000 patients, and we have our mobile clinic. So we'll be speaking from the perspective of introducing behavioral health and telemedicine onto our mobile clinic.
Thank you. And Emily?
Hello, everyone. My name is Emily Culo. I'm the Director of Mobile Advocacy and Meaningful Access at the Ohio Domestic Violence Network, and I oversee our new health access project that I will be talking with you about today.
Thank you. And Renee?
Hey everyone, my name's Renee Red. My pronouns are she, hers. I'm the Supportive Services Program Manager at the Survivor Advocacy Outreach Programs, New Leaf Justice Enterprise. SAOP serves survivors of interpersonal violence, and the New Leaf program is a division of that that aims to support survivors in their long-term healing journey.
Thank you, and really looking forward to hearing from all of you later today. And we're also going to have time for Q&A at the end. But before I walk through our agenda, I want to share a little bit of background about today's topic. In 2021, the Family Violence Prevention and Services Act, which supports victims of domestic violence and their children, nationally received a historic investment of $550 million to assist states, territories, and tribes with providing access to COVID-19 testing, vaccines, and mobile health units, and specifically for domestic violence programs. And this was American Rescue Plan funding. Similarly, $1 billion in ARP funding reached nearly 1,400 HRSA health centers. Those health centers operate 13,000 sites nationally across the US and territories to expand health centers, build new sites, and provide mobile health care, and to advance health equity and health outcomes in medically underserved communities, also supporting COVID-19 care. So these goals align, and the opportunity to elevate health access for survivors at domestic violence programs and for health center staff to receive support from domestic violence programs and to refer patients is here before us. This webinar can help us imagine and consider new opportunities to offer mobile health and mobile advocacy to patients and clients, and consider recurring visits to offer health education, health enrollment on site at domestic violence programs, and other health services, including oral health, child immunizations, prenatal care. So our speakers today are going to elaborate on these ideas. First, we'll define domestic violence programs and health centers. Then we'll hear from James about the national landscape of mobile health programs and a definition. What is mobile health? Next, we'll hear from Dr. Winford about her health center's mobile health program and how they integrate behavioral health. Following, we'll hear from Emily to discuss the Ohio Network's health work and community domestic violence program support, followed by Renee, who will share her domestic violence program's health program with us. Finally, we invite you today to share your questions in the QA feature and any comments in the chat. And we'll close the webinar today with some key resources for you to know about, and we'll share a post-evaluation so you can give us any of your feedback. Next slide, please. So I want to start here with this study conducted by the National Hotline on Domestic Violence in June and July of 2021 with 3,400 surveys that were administered to callers of the hotline. It found that more than half of survivors who called into the hotline at that period reported that a partner controlled or restricted their access to healthcare. This is an important takeaway for health centers that are looking to reach folks most underserved. And it's important for advocacy programs that are in a unique position to intervene and reduce the health consequences related to experiencing violence and abuse, including traumatic brain injuries that can result from strangulation or head injuries, as well as reproductive health problems, and to promote ongoing wellness, including connections to substance misuse programs and mental health support. Something else that this study showed us is that 42% of the callers said that their healthcare provider spends time alone with them. That means that almost 60% don't have one-on-one private time with their provider. And so that's something that we want to shift, and that's part of our CUES intervention. And we're not going to get into that today, but we will share an infographic in the chat where you can learn more about that CUES approach. So these statistics here on the screen reinforce how important it is to address the health needs of survivors, just as they're entering domestic violence or human trafficking programs. And it may be the first time in a long time that they and their children have had access to health services. Next slide, please. One thing to know is that being a survivor of domestic violence is considered a qualifying life event, meaning survivors can enroll in healthcare anytime throughout the year. This is really unique. So for health center staff on the webinar today, think about your enrollment specialists and the opportunity to connect with local domestic violence programs and enroll survivors and any children in an ongoing way across the year. On the right-hand side of this slide is a little picture of one of the enrollment tools that we have that outlines how this works and talks about the special enrollment period for survivors. So check that out. We'll share the link in the chat and take a look at those two enrollment memos that we have for you. Next slide, please. I'm going to tell you a little bit about health centers and why they're such unique partners. And this is particularly important for community-based programs such as domestic violence or human trafficking programs, because health centers are such important partners for you to know about. Health centers are community-based and patient-directed organizations that deliver comprehensive, culturally competent, high-quality primary healthcare services. They provide services regardless of a patient's ability to pay, and they charge for services on a sliding scale fee. Health centers also often integrate access to pharmacy, mental health, substance use, and oral health services in areas where economic, geographic, or cultural barriers limit access to affordable healthcare services. They also offer what's referred to as enabling services to help patients with transportation, health education, and language interpretation. And there's a URL on the bottom of the slide, findahealthcenter.gov, that'll help you identify the health centers in your area. Next slide, please. In many communities, domestic violence programs often serve as primary referrals for both domestic violence and trafficking survivors. In fact, for many survivors of trafficking, they may contextualize their experiences within the context of a relationship, such as with their boyfriend, husband, or other family member. So domestic violence advocacy programs and advocates have the know-how to work with and support survivors through immediate and long-term safety planning. And they can help increase survivor awareness of the unique legal, criminal, and housing supports that are available to them. Most offer 24/7 crisis lines. They support all kinds of, whether it's for adults or children, as well as employment support. And you can identify your local program through the link on the slide by first finding your state or territory coalition and then connecting with them about their member programs. Next slide, please. So HRSA's investments have advanced the nation's health by ensuring more patients and communities each year have access to high quality, comprehensive primary care. And you heard me mention this expansion, both of the service units and the mobile health that's offered across the country. Today, HRSA funds nearly 1,400 health centers that operate almost 13,000 delivery sites across the US, territories, and the District of Columbia. The staff who work at health centers number around 252,000 people, and they serve nearly 30 million patients every year. That's 1 in 11 people across the country. And health centers have more than tripled the number of patients served since 2000. So they're growing and expanding, and they have a value to partner with community-based organizations. Next slide, please. On the other side, the Family Violence Prevention and Services Act funded Domestic Violence Service Network funds over 1,200 domestic violence shelter programs and another 250 non-shelter programs, as well as state, territory, and tribal coalitions. They also fund the National Hotline on Domestic Violence, which is 24/7 and uses a multilingual language line. They fund also Strong Heart's Native Helpline for Native American callers and Love is Respect. Next slide, please. So the heart of our model is building these partnerships between domestic violence programs and community health centers. On the advocacy side, we want to increase survivor and staff access to health services and inform advocates about what health centers offer, including opportunities to enroll clients year-round. For health center staff, sharing warm referrals or information about domestic violence programs with patients is an important way to reduce isolation, improve safety, and open a lifeline to other supportive services. These referrals, remember, also benefit staff on both sides, staff at advocacy programs who don't have health insurance or a medical home, and staff at a health center who need the kinds of safety planning and support that a domestic violence program offers. Next slide, please. So especially during COVID, and now that many of you are also thinking about emergency preparedness, these partnerships were really meaningful, and they will continue to be meaningful in the event of an emergency. You can see here on the slide the types of support and benefits that a partnership can offer. And this also includes child vaccination and well visits, access to prescriptions, medication refills, and help to facilitate services for children who may need early interventions and other developmental needs. But you can see ongoing health enrollment, establishing a primary care provider, and all kinds of robust COVID support was very meaningful in the last few years. So I'm going to turn it over now to our first speaker, James, who's going to elaborate more on a definition of mobile health and some about the landscape of programs nationally. James?
Thank you. So just a general definition, in its most simple form, mobile healthcare is a care delivery model that brings that care to the people that need it. So it is, we could come up with a very complex definition, but I like that simple one because it really encompasses all the different ways that care can be delivered to people where they need it. So all across the United States, there are a number of programs that deliver any kind of care that you really can think of. It's being delivered today across the United States through mobile health programs. So it can be a portable dental clinic that has portable chairs that are set up in a gymnasium where dental professionals can see kids for their dental needs in rural areas. That could come in a van, it could come in a trailer. There are dental programs that go all the way up to tractor trailer size mobile clinics with 12 operatories that are able to do extractions and all sorts of restorative dental care. It really is about how to get the caring professionals to the people who want to receive that service. It also looks dramatically different with regards to how things get around. So I know personally of programs that are on trains, boats, 747s, and everything down to a regular minivan that goes out and provides care on the street to folks that are homeless, giving care directly right on the side of the street. So mobile healthcare really is exciting to me, and the fact that there are so many different ways that we are able to bring that care to people that need it. So the second thing that I think is important is, so how do we determine what area of focus or what patient population should we choose? And there are multiple different ways, things like county health assessments. Most health care systems, hospital systems are required to do a community needs assessment, and they make that available to folks in the community. Those are the kind of big picture ways. And then the smaller picture ways are things around who are the formal and informal leaders in a community that you need to connect with to help you understand what's happening in this county, city, town, neighborhood that would be helpful for you to understand. Because I've seen programs that are very passionate about, say, asthma care. And they buy this big giant $250,000 unit and they go to a neighborhood. But what they haven't figured out is that there is already a lot of asthma care in the neighborhood. And folks don't need that. But what they really need is diabetic education. And that doesn't exist. So the other thing I would remind you is to just kind of be flexible about what you think about, and be okay with transforming your program into things that we need. Lots of mobile programs transitioned into or created around COVID testing, COVID treatment, and COVID vaccinations. Now those programs need to transform into something different in the community to keep those resources going, because there's nothing worse than a really expensive mobile unit sitting in a parking lot someplace unused. And so I told the folks on the call earlier a story about those informal leaders. So in Central City in New Orleans, which is a fairly low income community, the person you need to talk to is Miss Terry. So Miss Terry knows everybody in the neighborhoods. If you have anyone in the neighborhood with a mental health issue, Miss Terry is the person to go to, because she's going to be able to rally the resources in that community to help that person get into the care that they need. And so, yes, you go talk to the city council or the town council or the parish, we have parishes, not counties, the county president, all those people, you talk to them, but you have to find the Miss Terrys of the world, because they really help you make that connection. And so the other thing about mobile healthcare is it's different. It isn't just recreating the same bricks and mortar type of care that you do in a clinic. It really requires a different relationship. It requires professionals on the unit that are okay with, for instance, working in very tight spaces, being kind of on top of each other. Lots of people don't function well in that environment, but that's the environment in a mobile. And it requires a different relationship, because you're going to have to build trust with the community, and you're going to have to build trust with the people that you care for. And I would say, especially in the domestic violence environment, that trust is probably really hard to get. And so connecting with those programs and bringing those things together and getting those warm handoffs helps with creating the trust. I believe mobile healthcare has a very close, intimate relationship between the person receiving care and participating in care and the person giving the care. And so that relationship is different than any other relationship with a healthcare professional. And it's important to recognize that and honor that for the participant and also for the provider, that those relationships are really important and must be developed. And then finally, I'd just like to share a little bit about some resources that might be helpful as you begin to think about mobile. One is the mobile health map. And so all you have to Google is mobile health map. And that is a collaborative project between Harvard Medical School and the Mobile Healthcare Association, which lists mobile health programs all across the United States. So it's a good place to begin to look and see, is somebody else doing what I'm thinking about doing, and maybe we can connect. And then the second thing it does is it helps you get a kind of rough back of the envelope return on investment. So if I saw X number of primary care patients in an underserved community, about what would that save the healthcare total delivery system in savings, right? In that case, it would be probably in savings in emergency room utilization. And so it kind of gives you some information that you can use, especially with grant funders, to talk about the impact of the work that you do in your mobile and how you might be able to leverage that for more resources from other folks, be that funders, foundations, hospital systems, and insurance plans. And then secondly, the Mobile Healthcare Association is a relatively inexpensive way to gain access to a whole bunch of information. Membership is $299 for an organization, and it opens up to you networking, relationships with vendors. It helps you with a whole bunch of research that we have compiled about the effects and the impact of mobile healthcare. We have a national conference in the fall, which is probably the only place where folks in mobile can meet the other person that does exactly what they do. And so there's lots of networking and education. And for folks that are newer in mobile healthcare, we have an intensive training course, which I co-lead together with Robin Gardner, who is a mobile provider in Canada. So the two of us provide this training in September, and it's the day before the conference starts. We also do one, we'll have one next month, kind of intensive for folks that are very new. And so it's a really great resource, and I encourage you to look at both of those things to see where we might be able to assist you in the work that you do every day. And I'll close with thank you so much for what you do. I know sometimes I hear that, like, thank you to community health centers for all you do. But truly, in both spheres of environments for folks on the call today, the work that you do is really important. And thank you.
Thank you so much, James. That was some sage advice, a lot of good resources and information there, and training opportunities as well, conferences and your training. I'm going to pass it to Dr. Ebony Winford, who's going to tell us more about her mobile health work.
Hi again, everyone. Before I get started, I want to make sure I acknowledge that our Director of Mobile Health, our RN Devin Hammonds, is here on the call with me. So just shout out to her, because she is the one who makes all this magic happen, and I can't pretend that we do it in isolation. But as one of the leaders, there she is. We are one of the leaders of integrated care nationally. And in fact, I'm the clinical director of consultation and training, which means I get to teach people how to do integrated care. Well, we bring in behavioral health providers to work in primary care settings. And just like James said, the pandemic gave us opportunities to extend our care beyond the four walls of our clinic. And so we have prioritized partnering with individuals without homes. And so we went to the only homeless shelter in all of our city here in Knoxville, and we collaborated with them to identify specific needs and specific times and days when we could be most helpful. Like James said, we couldn't just show up and assume that the need was there for us to provide services. So I can attest to the fact that don't come where you're not invited, okay? But the coolest part, there's so many cool parts, but the coolest part about our mobile clinic is that we use telehealth to provide behavioral health services at the point of care. So anyone who comes onto the mobile clinic, if there is a behavioral health need, they can meet with me or a colleague like me. We have an on-call schedule So I'm the Tuesday person. So anybody who is on the mobile clinic on Tuesdays, if there's a behavioral health need, I get a message and I connect via Zoom to that patient on the mobile clinic. We also do a lot of telehealth with our primary care services. So again, Devin, our director, is also RN, so she's on site, hands on the patients. She is the eyes, the ears, the hands, the nose for our medical provider, who's typically a family nurse practitioner who is also connecting via telehealth. That allows us to, one, build relationships, but two, we don't have to have a physical person traveling back and forth to the site of the mobile clinic, and we can still meet the needs of the community when they show up. Of course, there are opportunities and times when you need to be there with the person to touch them. Thankfully, we have a brick and mortar clinic across the street from where we typically park our mobile clinic. Ironically, we have a brick and mortar clinic across the street from where we park our mobile clinic, but just because we built it, they did not come. It was not convenient for them to leave the location where they're staying to go across the street and come into a clinic. So they do come to the mobile clinic. So again, we can do screeners, and we do screen for depression, substance use. We are working to implement universal education of intimate partner violence in all of our clinics, including the mobile clinic. We also are going to be attending the Mobile Health Association's conference in Pittsburgh this year, because we're part of the collaborative this year, where we are working to enhance and expand access to long-acting reversible contraceptives using our mobile clinic. And that would provide a perfect opportunity for the inclusion of behavioral health in that universal education about IPV, learning about ways to still provide contraception in a way that doesn't put the person who's getting the contraception at risk, for additional harm by their partner. And so we're really looking forward to expanding the way that we provide care. But I will say technology has really helped us to meet needs when people show up. I can log on, take care of them, collaborate with the team, and they don't have to go to a whole nother place or a whole other location. For me, if I can't take care of the patient while they're there, I failed them and I failed my team, because we don't know when we'll get a second chance for the patient to return. So if anyone is interested in integrated care as a whole, or how to integrate behavioral health, contraceptive, whole 9 yards on a mobile clinic, we'd be happy to help you. And again, Devin is up here too, so I may be punting some questions to her if it's something that I can't address. But thank you all for the opportunity to share the ways that we are pulling those things together.
Thank you so much. And that's so inspiring, especially in terms of reproductive support for your patients. And that's something that a lot of survivors of domestic violence are also interested in. So thank you for your work. And after hearing from James and Dr. Winford on the community health center side, we're going to shift gears and hear from Emily and then Renee some about the domestic violence space, coalition and local program, and some about how they're approaching health support for their clients. I'll hand it over to Emily.
Thank you, Anna. So again, yes, my name is Emily Culo, and I work for the Ohio Domestic Violence Network. And so we are the statewide coalition for Ohio. A little bit of background on Ohio is that we are a technically urban state. However, we have a lot of very rural communities in Ohio, including some Appalachian counties, which you'll hear more about when Renee speaks. And we have 88 counties in Ohio, and about 75 domestic violence programs across the state that serve all of those 88 counties. And so we were very fortunate to, receive some of this FIPSA funding that allowed us to, for the very first time, really look at building the connection between domestic violence and healthcare, and specifically, doing things like screening for different health-related issues with the survivors that we are serving. And I'm sure it's very similar to many states that, we ask a lot of questions historically around the criminal aspect of domestic violence and less about the holistic issues that are impacting all of these survivors and specifically around their health. And so this has been a really amazing opportunity that we have had to be able to focus on that. And we approached this project really twofold. So the first piece of this project, we have a 3-year project to better build connections between local domestic violence agencies across Ohio and their local community health centers or other health agencies that exist in those communities. And we are doing so by providing a mobile advocate that can provide mobile advocacy around health-related issues, as well as also screening for the other issues impacting a survivor's social determinants of health. So allowing domestic violence advocates to meet with survivors in the community. As Ebony mentioned, survivors need to be able to meet with people and not have to come into our DV programs, come into a community center to be able to receive services. And so this allows advocates to actually get out of the shelter, get out of their offices, drive and meet the survivor where they are, screen for all of the different things that could be impacting a lot of different issues, and specifically around their health. And then we are able to also, through this project, partner with local community health centers on the ground to be able to potentially have an advocate at that health center that can meet with survivors. Our focus is on creating a streamlined referral process for those survivors. So better screening in the DV agency, but then also better screening within the healthcare setting as well to really capture who is walking through those doors. And so that is a on the ground effort that we are able to do. And Renee will talk with you more about specifically how we're building those relationships, but it's been very important for us that we focus on capacity within those communities to build the relationships with their health centers, right? So we know that if you're, on the DV side of things, we're really good at building connections with the different resources that exist. And I know that that's true also for healthcare and for community health centers in particular. And so just kind of creating another door to be able to refer to and from. The other big piece of this project that we are focusing on is around behavioral health. So, and I'm sure that I am preaching to the choir in this, but behavioral health is something that really is needed with the population that we are serving, and something that is really impacted by wait lists and lack of practitioners, especially when we talk about some of these very rural communities, right? And so in Ohio, we have a lot of very rural communities that just don't even have enough behavioral health clinicians. And so they're often referred to our larger cities like Columbus and Cleveland and Cincinnati. And then those clinicians have very long wait lists, right? And so our other piece of this is creating a network of clinicians that are eager to serve specifically survivors of domestic violence, and provide some brief therapy for those individuals to be able to then better connect them with a more long-term solution, but something that really can happen now so that survivors have the best success rate when they're navigating these different systems. And so we have the ability to provide payment for healthcare for survivors who do not have access to private insurance or Medicare or Medicaid, as well as additional health-related costs that maybe aren't covered by those things. And then also the ability to pay for some of those practitioners when necessary to be able to remove that barrier for survivors. And so that's really kind of the whole project that we are working on. Our biggest goal of this is to provide better access to care for survivors of domestic violence and create a sustainable model of advocacy around mobile health for survivors, so that after this after we walk away from this project, after this funding is done, that DV programs feel that they have the capacity to be able to network with their community health centers and really, just focus more on all of the different health related needs for that survivor, everything from their physical health, their reproductive health, their cognitive health. We do a lot of work around survivors with potential brain injuries, and then also those survivors with substance use and mental health issues that need to be addressed as well. But I will let Renee kind of tell you more about how their relationship between their community health center and SAOP has really been an organic thing that has been amazing to witness.
Yeah, thank you so much, Emily. Again, my name is Renee Red, and I work for the Survivor Advocacy Outreach Program. SAOP is a nonprofit. We provide services to survivors of interpersonal violence. We have a 24-hour hotline and 5 advocates that do crisis response in a 9-county service area here in Appalachia, Ohio. All of our counties are Appalachia, Ohio, and we're really proud of that. So essentially, advocates doing crisis response, they are pulling people out of the metaphorical river of trauma, right? Once they've fallen in. And I'm fortunate enough that I work for one of our programs called New Leaf that was developed by our executive director in the midst of COVID. And the intention of that was to help survivors heal from trauma and prevent them from falling in the river again. And also hopefully to prevent their children and their grandchildren from experiencing the trauma of interpersonal violence. And we do that by providing 2 years of free housing that includes utilities, internet, cleaning supplies. We offer living wage employment at a minimum of $15 an hour at our New Leaf Marketplace Cafe. And we also provide supportive case management services and workforce development training. So at New Leaf, one of our main goals is, of course, to provide and increase access to healthcare for the survivors in our program. And as we kind of already touched on, there are a lot of reasons why they hadn't been accessing healthcare up until that point. Yeah, so sorry about that, David. And yeah, so the reasons why there are so many barriers to survivors accessing healthcare, specifically in Appalachia, but probably in other places as well, is that lack of transportation piece. We don't have buses that can take folks to a city center in a lot of the areas that we serve. There's also so many places here in Southeast Ohio where when I say there is no Wi-Fi or phone service, there is none. So the option for folks to log on and access healthcare that way is simply just not accessible. There's also a lot of shame that survivors experience from having put off their appointments for so long. And there are also not an adequate number of trauma-informed providers for specifically LGBTQ folks in our communities. We worked with folks who have experienced blatant discrimination when they have attempted to access healthcare services, survivors who haven't been believed, and who maybe have experienced judgment for the choices that they made. So that's why I'm really excited to talk about the partnership that Emily at ODBN has helped us to create with Equitas. Equitas is a regional nonprofit health system that serves the healthcare needs of the LGBTQ plus community, people living with HIV, substance use disorder, and others in need of healthcare. And because of this partnership, Equitas will be providing a mobile health bus that will come on site here in Nelsonville, Ohio, which is where our first New Leaf community is, but where also our crisis advocates can then bring their clients to this bus as well, which we're really happy about. But developing this partnership was many years in the making. Partnerships in Southeast Ohio require a lot of time, intentionality, and care. And so I've been working with Equitas when I was an advocate, doing crisis response work, providing them with a lot of referrals, but also always inviting them in to train us. So we understood that they had a wealth of knowledge and wisdom about the populations that they were trying to reach. And so we wanted to make sure that we were equipping our advocates with that information as well. And because we invested and honored their knowledge and wisdom, they were very receptive to partnering with us when this time came. And we also attempted to make partnerships with other health centers that didn't work out. And that's just because sometimes other health centers don't have the capacity to do this, but Equitas, it managed to work out really well, and we're very excited about that. Equitas is going to be providing us with, in addition to the mobile health bus, trauma-informed providers who truly understand the importance of trauma-informed care, specifically around substance use disorder and gender-affirming care. And because of this, now the folks in our program who have not been able to access healthcare for a variety of reasons will now have that opportunity, and are really grateful. And I was really excited to hear you, Dr. Winford, talk about kind of combining that physical health care with the behavioral health care through telehealth. So that was really cool to hear about, and thank you for sharing that.
Thank you so much, Renee, Emily, Dr. Winford, and James, for your insights and just for sharing the operational, how it's working, and how you got there in terms of the early conversations and planning and outreach. A lot of really inspiring, I think, information and a lot of seeds, a lot of food for thought there. So we're going to open it up right now, and I want to invite everyone, all of the attendees here, please share your questions for our speakers. You can put them in the Q&A function at the bottom of the screen, and you can share any other comments or things that you want to share about your own work in the chat, and we'll look at those as we go. Do we have any questions so far? I'm just looking at my co-hosts. So we'll give you guys a moment, attendees. Feel free to use that Q&A function right at the bottom. And I'm going to invite my colleague, Dr. Chang, if she caught anything in the chat. I haven't been watching the chat as closely. Dr. Chang?
Hi, no, there were no questions except for questions about the resources and the links to the conference and mobile health conference in Pittsburgh. I do have a question though,
Go for it.
all of the panelists. And my question is, since there are both innovations in the community health center side for mobile health and the domestic violence program advocacy side for mobile health, how do you suggest, or how do you envision getting, if those two mobile health programs exist in the same community, how do you envision getting them to collaborate and work together to assist patients and clients? Maybe James can start first, since he's been doing this work for many from
Sure. I think the very first thing is just reaching out and saying, from the community health perspective, is that we have patients that you could see for us, and we can make referrals to you. I mean, I think from the community health center side, that's the kind of first entree is, ooh, you have patients. We like to take care of patients. And then when you kind of engage us, then it's the conversation of, now let me tell you what else I can do for you, help educate you on domestic violence issues, help educate you on how to be on the lookout for those things. And then you might need our services, and here's how you refer into us. So it's that first outreach, I think, of just building the relationship of like, hey, you may not know about us. We need to sit down and talk. I don't know, Dr. Winford, do you have any other things that would be like things that would pique your interest about hearing from folks?
Yeah, I'm always a big fan of community assessments and hearing where the need is in the community. So for example, if we were to try to form a stronger partnership here in Knoxville, there are at least 2 organizations within our community that provide resources and support for people who have survived domestic violence. And I would not want to just bring the mobile clinic there. FYI, we call our mobile clinic Bertha, Big Bertha. And again, Devin, our director, drives Big Bertha and serves as a nurse. I just had to make sure I threw that in there. But I would not pull Bertha into their parking lot. Instead, I would leverage, like you said, relationships and existing communications. And yes, we have been able to meet with them. They've trained some of our clinicians. So just saying, hey, we can do this. We understand there, healthcare may be a barrier for some of the people you're serving. We'd be happy to come to you. You don't even have to bring them to us. And I think demonstrating that we have an added value might be the best strategy. We don't want anything from you. We just want to partner with you to make sure you're taking really good care of the clients you're serving.
Thank you so much. And today we're spotlighting mobile health, but there's so many ways to initiate a partnership. And it might be, as James was mentioning, connecting with the community advocate and inviting them in. Maybe there's an opportunity for them to present to your health center staff about domestic violence and about their services and what advocates do and what's available right there in the community, not only for patients, but also for staff who might need that same kind of support in their lives. And we're going to go over some tools in just a moment after our QA to lift up some resources to help formalize these relationships, and also a policy on intimate partner violence and human trafficking. And I'm looking just at the chat, and Rebecca shared that she's the director of nursing for Central Neighborhood Health Foundation, which is an FQHC serving 3 counties in Southern California. And they're starting to offer mobile clinic services to domestic violence shelters. Thank you, Rebecca. That's awesome. In Los Angeles. But they're starting from ground zero, and they're having trouble putting together policies specific to mobile clinics. And they'd love some guidance or direction. And I'll jump in first and then pass it over to anyone who wants to respond. Just to say that we do, as I mentioned, have a policy on intimate partner violence, human trafficking, and exploitation. It was crafted more for the brick and mortar setting. However, it can be adapted, and it goes over the intervention, the evidence-based cues intervention, and it has definitions, and it talks about how often and who does what. So that's going to be a really great adaptable resource, and that might be something you want to amend for the mobile health study. But let me ask my co-facilitators here, does anyone else want to touch on Rebecca's question?
So I'll say that your FQHC policies generally translate to mobile care. So the same kind of policies that kind of govern your work are the same ones there. The things that'll be different is the procedure. Like, how do we do particular things that would need to be tweaked for the mobile environment? But I would say that, like, start with what you have and adapt the procedures to how you do things on the unit. And then the second thing I would say is the mobile healthcare environment is very giving, and they share resources. So networking is the #1 way to gain those resources. And so reach out to whatever program you know about. And then when they say, well, we don't have any, then say, well, who do you know that you might be able to connect me with to help me? And the person in the comments, when you've seen one mobile clinic, you've seen one mobile clinic, is absolutely true. But the basics of what we do around care is generally from what you normally do. There are other policies and procedures around how do you maintain your vehicle, how do you take care of medical waste on a vehicle, how do you take care of black and gray water, and how do you do all these things are very specific to mobile healthcare. And those you can find by reaching out to the greater community of mobile programs.
And I like some networking happening in the chat, and definitely some interest. This is, a new collaboration for some, and we're going to continue the conversation as we go. This is just our first kickoff webinar, but this is something, we're hoping to connect with more programs nationally who are undertaking this kind of collaborative work. So I want to lift up quickly, we have a adaptable MOU to establish this kind of a partnership between a community-based organization and a health center. It's in English. We have a version also in Spanish. And it really helps to formalize, to put it down in writing as staff turns over and time moves forward. It's great to have that to look back on, to remind ourselves, how are we working together and what can we offer each other? And you'll see that also on our website and our toolkit. Next slide, please. And also it'll be in the chat. I think we're gonna share the chat, a link in the chat in just a moment. And this is the protocol that I mentioned. Dr. Kimberly Chang, who's also faculty to our NTAP, was instrumental in making this happen. We piloted it with a number of health centers across the country and domestic violence programs. And it's adaptable, it's in English and Spanish. And really it's for you to amend and adapt to your setting to make it work. But there's a lot of information, not only for primary care, but also specific to adolescent health. So definitely check that one out. And next slide, please. And we also have setting and population specific safety card tools. And these are to help when you're doing the intervention and you're talking to patients or clients, to share 2 safety cards with them. One is for them to take for themselves, and one is for them to share with a friend or family member. And we have them in different languages for pediatrics, for reproductive health, for elder care. So there's a range of these safety card tools to help you open these conversations with your patients and clients. And you can find those in our online store. And then finally, I want to make sure everyone walks away knowing there are national organizations that can support you. The National Domestic Violence Hotline is always a resource for patients or for clients, especially if you're in a more rural area where there might not be a domestic violence program that's right there. You can always refer to the national hotline for support, 24/7, multilingual. They're also online, and they have a chat feature that you can use online. Strong Hearts Native Helpline has some limited hours. However, it goes to the national hotline on the off hours. And Strong Hearts Native Helpline is for Native American and Indigenous folks with trained counselors, and also has a multilingual ability there. And finally, Esperanza United works with Latinx programs all over the country, domestic violence, sexual assault, human trafficking programs. So definitely check them out if you're looking for a culturally specific program in your area. And finally, for the advocates on the line, if you're not yet working with a health center, check out findahealthcenter.hrsa.gov to identify the closest health centers in your area, and maybe partner with a few of them, maybe some right where you are and some that are outlying for some of your outlying clients. Next slide, please. And just want to share that for those of you who speak Spanish or have colleagues who speak Spanish who might be interested in learning more about our evidence-based cues intervention and our Spanish language tools, we have a webinar next week, April 26th, where we'll be talking all about these new tools and approaches with our partners from Puerto Rico and from Esperanza. So definitely join us. There's the link in the chat. You can click there and open that registration and join us next week. And then finally, we're going to invite you to complete our evaluation. We'll put it in the chat. It's right there in English and Spanish. And let us know, give us any feedback or what you're looking for in future conversations. And we also have a range of additional resources that we haven't talked about today on our website, healthpartnersipve.org/general-resources. And I just want to extend some gratitude that's coming in through the QA and through the chat for our speakers. Really wonderful perspectives, a lot of inspirational ideas. I think just hearing about it excited me in the ways that you're already working and the opportunities ahead. So stay connected. Let us know through the evaluation if you have more questions or would like to get in touch with any of the speakers. We can help make those connections. And just want to thank our speakers, our captioner, Jen, and our ASL interpreters, Hillary and Tabitha, and our Spanish interpreters, David and Andrea. Thank you everyone for joining. Enjoy the rest of your day.